Hello, everyone. Good morning. A lovely day for the ones who have already given the exam. This is your first day post exam where you can chill, right? And for the ones who are preparing for your December or a January exam, this is a very important session because this is going to give you an insight into how the exam questions might be in your exam. So, coming to all the students who've given the exam, hope it went well. It was a moderately tough paper, is what I get to know. Less of PYQs, less of image-based questions, more of text-based, descriptions and clinical scenarios. A little tough phrasing of the questions, a little tough English is what I've come to know. I hope it was something that you could read, attempt, think. This was a question paper which demanded clarity of concepts, which demanded you to have studied in depth, read the lines in your notes, read the lines in your books, maybe, and not just do one liner, rapid revisions. That is what each and every FMG paper over the last 5 years is telling us. With every consecutive successive paper, this is what is the core bottom line that comes out, that when you read in such a way that you form your concepts, that you build your foundation, build your basics, because in the question paper, they are not assessing just your, fact based knowledge. They are actually assessing your understanding of the subjects. A lot of questions in this paper also were repeat. They were from the previous year papers, but they were not direct word to word repeats. These were more of previous year topics which were phrased a little differently. A lot of questions here, I will tell you, are direct INI NEET PG questions. So much so that there are two questions which were there in INI CT May 2025, and they have now been asked in the FMG paper as well. So, as I always tell you in the class, when you do your question banks, it's all very good. But just remember, the last 5 years NEET PG papers and INI CT papers are also legitimate questions. These are questions that have been framed by the examiners who are framing your questions. So these are legitimate questions which you should also be practicing as you practice your Q banks and your FMGP by Qs. So that's a very important learning that we get from here, because a lot of direct questions from these papers I'm seeing here. So starting with the discussion, these are strictly the first recalls received from the students. There might be some discrepancy in the questions, in the options. Please note that in the comments, in the chat, because this will help us make a proper recall. And, as I discuss in all my classes, as I discuss in all the hit sessions and rapid revision sessions, 60% of my class time is based upon infections. And I would tell you, this is the most important topic for your exam, also proven in this paper, that almost all the questions that I have received are infections barring one. So that tells you further, drills in the importance of reading infections for your exams, because by asking questions they integrate dermatology, microbiology, pathology, medicine, peds. So 5 subjects catered by one question. That is the beauty of infections, and that is what this whole paper is about when we come to derma. So coming to question number 1, please do tell me about any discrepancies or any change in language or options as you see this. So in this paper, a 4-year-old child came with fever, sore throat, poor appetite since 2 days. On examination, there are multiple vesicles on palm, soles, and oral mucosa, as shown in the image. Several other children in the daycare have similar complaints. What is the causative agent? So, this is a question where it is a child with fever, vesicles. You see that in the image also, they're present around the mouth, on the hand, on the feet. What do you think is the... Good morning, dear students. Tell me, what is the causative agent here? So you have fever, vesicles on palm soles and oral mucosa. You also know that this is an infection since there are other children in the daycare who have similar complaints. So when it tells you another sibling has it or someone else in the family has it, other children in the daycare have it, they're very well telling you that it might be something that is contagious. So what are the options here? We have Coxsackie A16, parvovirus, human herpes virus 6, and adenovirus. Which of these viruses causes a disease with these clinical findings? So let us see. Adenovirus would cause fever, would cause sore throat, poor appetite, but it will not cause any vesicles. It will not cause any vesicles. Yes, there may be a red rash in some patients who have an adenoviral pharyngitis, but it does not cause any vesicles. Human herpes virus 6 causes the disease, which is roseola infantum. Again, it would have fever, it can present with poor appetite, it can present with a rash on the body, but that is again a red rash. There are no vesicles here. Parvovirus B19 causes erythema infectiosum. Again, you get a red rash on the face, which is the slapped cheek appearance. There are no vesicles here. The only one which causes the disease with fever and vesicles on the palm soles and oral mucosa is Coxsackie A16 because this causes the disease hand foot mouth disease, which classically has lesions on the hand, feet, and the mouth. So, a direct repeat from your August FMG exam, a very favorite of the INI exam. They love asking fever with vesicles. All of them show vesicles except. So this is like a very basic question that's a favorite of all the exams, has been repeated in this exam as well. So the correct answer here is option A. That is Coxsackie A16. Look at this. This is the hand, foot, and the mouth disease. This is an enteroviral infection, spreads via the GI tract. So very very common in nurseries and daycares, primary classes, where students tend to put their hands to the mouth, take in the infection. Very, very common. And children in the daycare having it is a very, very important clinical scenario where you get HFMD. The causative organism most commonly is Coxsackie A16. It can also be caused by enterovirus 71. Classic description would be a child with fever with vesicles on these locations. And look at the vesicles here, very beautiful. These are called as elliptical or angulated vesicles. So this hint has been given in the INI ones, elliptical vesicles. So this is something that you have to remember. This is HFMD. Coming to the other viruses which were there in the options, C. parvovirus B19 causes erythema infectiosum, which is also called as fifth disease. Here, the child presents with this reddish rash over both the cheeks, which is called as the slapped cheek appearance. HHV6 causes roseola infantum, which is also called as sixth disease. Here also the child will have fever. Fever goes down, develops a red rash on the body, but this is again a red rash, no vesicles here. Oral cavity findings, Nagayama spots. Nagayama spots in the oral mucosa. Now, parvovirus B19 was a question asked in your July 2023 exam. Roseola also they keep asking in the options. So you have to know these two diseases as well. They are important. Coming to the next question. A 28-year-old dentist presents with painful grouped vesicular lesions on the distal phalanx of the right index finger. She denies any systemic symptoms. Which of the following is the most likely diagnosis? So, what is the question saying here? Dentist? Painful grouped vesicles on the index finger, no systemic symptoms. What is the likely diagnosis? Paronychia, Whitlow, warts, or varicella? What do you think is the correct diagnosis here? Was this question there with these exact options? So, what do you think is happening here? Yes, paronychia is painful, but it is red. There is swelling and pus. there are no vesicles in paronychia. So paronychia can be on the distal phalanx of the right index finger. It can be painful, but there are no vesicles in paronychia. Varicella can have vesicles, but these vesicles are all over the body. Okay, these vesicles are all over the body. They are not limited to the index finger. So this is certainly not varicella. This is certainly not paronychia. Warts can be present on the finger, but they are non-painful. And they are not vesicles again. These are solid lesions. They may be papules, they may be plaques, but they are not vesicles. Now remains option B, which is Whitlow. What is Whitlow? What is Whitlow? Whitlow is a very important disease that is caused by HSV1. We don't see it so much these days because of the use of gloves. But in the earlier times, when a doctor would examine a patient's oral cavity, especially a dentist with bare fingers, a patient has herpes on the lips, it can enter from the cuticle of the doctor and enter the finger, cause an infection there. Or if it is a nurse who's administering some oral care, wiping the patient, again, the infection from the oral cavity can enter the finger of the nurse. Maybe if a patient has herpes labialis on its own and they are just touching it again and again, they can have it. So these are all the clinical scenarios where you can get this particular disease, which is called as herpetic whitlow. What is the causative organism? Since it's spreading more commonly from the oral herpes, the most common organism that causes it is herpes simplex virus 1. But remember, in certain cases, it can also be caused by herpes simplex virus 2, that is from the genital area. If it spreads to the finger, then the patient may have it due to HSV2 as well. Otherwise, remember this as the most common cause of herpetic whitlow. Commonly seen in doctors, nurses. I told you how it spreads. So what is the source? Source is the herpes lesions on the patient. Patient having oral herpes. How will it present? All herpetic lesions present in this way: grouped painful vesicles on a red base. That's classic of all herpes, whether you get it in the oral area, you get it in the genital herpes, you get it in the herpetic whitlow. So the presentation of herpes is going to be the same. The only difference here is that this is present on the fingers. So this is just an important point that you have to remember, that this is present on the fingers. Sometimes these vesicles can rupture. Patient can also have erosions. With this, there is another one that I will want you to remember. This is herpes gladiatorum. This spreads from contact sports. Suppose a patient is playing boxing, or there is a rugby where your hand is going to the face of the patient, touching the lips. So what will happen in such a case? The patient can have herpetic lesions somewhere on the face as well. So your face is touching the face of the patient, your herpes is going to the face. So you can have herpes lesions generally on the face. It could be on the forehead, it could be around the cheeks. So this is spreading from one person to another through contact sports. So that is another variant, herpes gladiatorum, which you should remember. Herpetic whitlow, herpes gladiatorum. If you would have other diseases, see, varicella would present with vesicles all over the body, not with vesicles on the fingers. If it were viral warts on the finger, this would be solid lesions, which will be papules. They can be larger, these can be plaques, and they will have a, look at the surface here. Look at the surface, you see that these are solid raised lesions, and the surface here is a rough or a warty surface. So this is something that you have to differentiate from the vesicles. This is just a morphological difference, very important difference. These are solid lesions with a rough verrucous surface, and those are vesicles. So that is an important differentiation you need to do. Paronychia can also get very confusing. Coming back to the question here, paronychia can get very confusing because this is also painful, this is also red, but this will have pus, it will not have vesicles. So it is very important to read what the question is telling you, to identify the keywords, and then mark the correct answer. So painful grouped vesicles, right index finger, dentist, where does this take you? This takes you to option B, that is Whitlow, as the correct answer here. Are you all with me? Yes? Getting how to differentiate Whitlow from paronychia? Getting how to differentiate Whitlow from paronychia? Good. So correct answer there was Whitlow. Now, a very, very important question. This was there in your FMG January 25. This was there in the INI November 24, INI May 25. उससे पहले तो multiple times in the INI. I can't even count the number of times they asked this. This is a very important and a very favorite question of all the examiners. And I hope that this was a sitter for you all. You all got it correct. So what is the question? Multinucleate cells in the Zang smear are seen in. So where do you see multinucleate cells in the Zang smear? HSV1, pox virus, varicella zoster virus, or a Coxsackie virus. Which of these viruses causes a disease where you make a Zang smear showing multinucleate giant cells? Coxsackie A virus definitely does not show it. Pox virus, that is causing molluscum, does not show multinucleate giant cells. Now, I'm a little confused here. I know that varicella zoster virus causes varicella, causes herpes zoster. The vesicles here can show multinucleate giant cells. This I'm 100% sure. HSV1 causes herpes, shows MNGs. So I am a little confused here. What do you think would be the correct answer? Both herpes simplex virus 1 infections can show multinucleate giant cells. Even varicella and zoster can show MNGs. So what do you think should be the correct answer here? Both of them can show this. So what do you think should be the correct answer here? Both HSV1 and varicella zoster virus can show. HPV was also there. Okay. So even if we consider, so which option was not there? Pox virus or Coxsackie? So either of them, even if HPV was there, here also Zank would not show MNGs. Okay. Zank would not show MNGs. So which one? Now we have to choose between either herpes simplex virus 1 or varicella zoster virus. Now, many a times in the exam, you have to give the best answer. You know, it may necessarily not be the correct answer. You also have to choose between options. You have to give the best answer as per the question. So VZV, that is varicella, and herpes zoster would be a cause, but what is the most important cause? What is the most common cause? Most common cause is the HSV1 and 2 infections. So the correct answer here is going to be option A, that is herpes simplex virus 1. See, whether it is causing herpes labialis, whether it is causing herpes genitalis, whether you are having vesicles on the oral mucosa, you're having vesicles on the genital area, whatever disease, you make a Zang smear, the finding that you see are the multinucleate giant cells. The most important finding here are the multinucleate giant cells, where a lot of keratinocytes break, join together to form this fused nucleus here. See, these are all the cells where you see this fused lobulated nucleus. These are all your multinucleate giant cells. A very, very important finding in these two diseases. And a second finding, which I will also want you to remember, are acantholytic cells. You see these keratinocytes, which are round with a large nucleus. These are all acantholytic cells. So there are two findings in hepatic smears. First is multinucleate giant cell. Second is acantholytic cells. These are cells which are keratinocytes. They have separated from each other. So they are round with a large nucleus. These are acantholytic cells. And what are multinucleate giant cells? Here you will see this kind of a lobulated nucleus. So this is your multinucleate giant cell. These two very, very important findings in the Zang smear. Yes, you can also see it in varicella zoster virus infections causing varicella, causing herpes zoster. So you can see it in both. But the more important ones are HSV1, making HSV1 the correct answer here as well. Okay, making HSV1 the correct answer here. Coming to question where again it's a child, they have loved asking infections in children here. So a 6-year-old child presents with multiple papules with a central umbilication over face and trunk. Smear shows HP bodies. What is the diagnosis? So, what is the diagnosis here? A child, papules with central umbilication on the face showing HP bodies. All the keywords possible for this diagnosis are there in the question. All the possible keywords are there. So a child can definitely have impetigo on the face. Child can have molluscum on the face, verruca vulgaris, and herpes zoster rare in a 6-year-old. So this is something that you would not consider unless it very strongly goes there. So you have to choose between A, B, and C. Which of these would be a papule with a central umbilication on the face? Tell me, what do you think is the correct answer here? What do you think is the correct answer? Which of these shows a papule with a central umbilication? Impetigo would be classic honey colored crust. It does not really show you papules. So these are honey colored crusted lesions on the face of a child. Okay, so no papules with an umbilication here. Verruca vulgaris, we just saw these are warts. What were the warts? These were definitely papules. Yes, but they don't have a central umbilication. They have a rough, warty surface. And it is molluscum, which is actually a papule with a central umbilication. Now, even if you don't know the morphology, even if you don't know the morphology, but somewhere in some corner of your mind, while revising micro, while revising path, derma, you may have read where are HP bodies seen? Yes, that's a very important hint in this question. Even without this, the central umbilication gives you the answer. But if you get HP bodies, that takes you right away to the correct answer. What is the correct answer here? Correct answer here is option B. That is molluscum contagiosum, because here you do get papules, you do get central umbilication, and you also get what the question is saying. That is the HP bodies. So a very, very, very important hint is the HP bodies. That is molluscum contagiosum. See, what is the etiology? Etiology is the mollusky pox virus, which belongs to the family of pox viridae. Common in children, on the face because it spreads by contact. So one child having it can spread it to the siblings, can spread it to his school friends. So very, very, a common scenario is a child presenting with molluscum on the face. Even the mother or the father can get it from the child. How does it present? Look at these beautiful pearly white dome-shaped papules with the central umbilication. See, what is a papule? A papule is a solid raised lesion. So this is a papule. Now papule can be flat-topped, papule can be dome-shaped. So this is what is the meaning of a dome-shaped papule. And how would a dome-shaped papule with a central umbilication look? See, this is the umbilicus. Like you have an umbilicus on your stomach, these papules have an umbilicus on their top. So this is what is the meaning of a central umbilication in the lesion. And when you see it from the top, you see this umbilicus as a small round pit on the surface. So this is a papule with a central umbilication. Look at this lesion here. This is showing you the classic central umbilication in a molluscum lesion. Now, sometimes these papules can develop along lines of trauma. So there can be an auto-inoculation along a trauma or a scratch, this can lead to multiple lesions in a line. This can lead to multiple molluscum lesions in a line, like you see in this image. What is this called as? This is called as the pseudocopnous phenomena. So this is called as the pseudocopnous phenomena, which is an important clinical sign that we get in patients with molluscum. So what are the points to remember? Caused by molluscopox virus, dome-shaped papules with a central umbilication shows the pseudocopnous phenomena. Whether you make a Zank smear or you do a histopath, both of them show the classic intracytoplasmic eosinophilic inclusion bodies that are called as Henderson-Peterson bodies. So a very important point here, inclusion bodies in molluscum, these are the Henderson-Peterson bodies or the HP bodies, which was mentioned in the question. Okay, so that is a very often, see how often this is repeated again. Questions from the INI in the FMG, this came last in 2019, but in the FMG it has come twice. So this is, telling you the importance of doing these papers as well when you are preparing for your exams. So this is your molluscum, the inclusion bodies, Henderson Peterson bodies. Most of these lesions would spontaneously resolve in 6 to 9 months. Most of these lesions would resolve on their own. We generally don't need to treat, but if at all treatment is required, imiquimod, 5-fluorouracil, and tretinoin can be tried in patients with molluscum. One more thing I would like to tell you, when it happens in a child, it's generally the face and the trunk that's commonly involved. When it happens in an adult, there could be a genital molluscum as well, which spreads as an STD. So you could get these lesions of molluscum on the face in a child, you can get them on the genitalia in an adult, but the morphology, the Henderson-Peterson bodies, all that remains the same. All that remains the same. See, this is impetigo. I told you this can also happen on the face of a child, but you see this beautiful honey-colored crusting here. That is the classic finding of impetigo. You don't get any papules with an umbilication. Zoster can also be on the face in a child, very rare because herpes zoster is secondary activation. So in children, you commonly see varicella, you would see zoster in the older people. But even if this were to happen, lesions would be unilateral. Lesions would be in the distribution of the dermatomal distribution. See, unilateral lesions, these are vesicles extending along the dermatome here. So that is what herpes zoster would be. And what was the fourth option? The fourth option was Verruca vulgaris, which we saw in the previous question, where you would see papules with a rough 40 surface. So important to know what is the correct answer. Important to know how you can rule out the other options as well. Now, a patient presents with fever after returning from a forest. The following finding was seen on examination. Which of the following is the drug of choice? Tell me, what do you think was the correct answer here? Fever, a very, very important point, fever, and that the patient had recently returned from a forest. So when you have forest or a trekking trip or anything of this sort mentioned in your questions, they are trying to tell you that there is a tick bite or a flea bite or some other, mite that might have, bitten the patient. So these are all important hints, important keywords that you have to catch from the question. What do you think here? Fever, forest, what do you see on the examination? An important image here. What do you see on the examination? You see this thick black crust here. This is called as an eschar. So, what would be the diagnosis of a patient presenting with fever and eschar after coming back from a forest? What would be the diagnosis? The diagnosis here could be scrub typhus. See, when you see eschar, you have to think of scrub typhus. And when you think of scrub typhus, what is the antibiotic of choice for scrub typhus? Tell me, what's the antibiotic of choice? What is the antibiotic of choice for scrub typhus? Yes, very good. This is doxycycline. You don't give penicillin, patient does not respond to ceftriaxone. This is certainly not malaria that we are dealing with. So no artesunate here. What is the correct answer? The correct answer is doxycycline. Scrub typhus is a very favorite of the INI exam. This similar scenario given in 21, given in 22. Before that, also, if you go to AIMS 2017, 2018 questions, they have loved asking scrub typhus. So that's a very, very favorite of the INI exam. And now they have asked in the FMG exam as well. So, what causes scrub typhus? Orientia susugamushi. This is a bacterial infection caused by the bacteria. How does it come? It comes from the vector that is the trombiculid mite. Actually, their larvae are called as sugars. So this could be in a farmer during the harvest season. This could be someone coming back from a forest who are exposed to grass and these mites. So this is the trombiculid mite, comes from their larvae, which are called as sugars. Patient commonly comes with fever and CNS signs and symptoms. When you examine the skin, you see the eschar, which is this black adherent crust. And in such a patient, the routine antibiotics which you would give for these CNS signs, like routine antibiotics which you start for meningitis, they generally don't work. So when they are not working, you examine the skin, you see the eschar, you start them on doxy, they respond very beautifully. This was a question in AIMS 2018. A patient with fever, CNS signs and symptoms, was given routine antibiotics like ceftriaxone. He was not responding. On cutaneous examination, eschar was seen. What would be the change in antibiotic? So, this is the similar scenario they have asked before, they have asked now also. The correct answer here is doxycycline. So, more or less, the questions, the important topics remain the same. They just keep changing the language of the question. Very important to know the important topics. Now, another question that they have asked, so I would want you to know, other than scrub typhus, what are the other causes of eschar? What are the other diseases where you would see it? For that, the mnemonic is stage, STAGE. What is S? S here is a spider bite. T is the scrub typhus. A is anthrax. And G is ecthyma gangrenosum, which is caused by the Pseudomonas. So, what are the other causes for this eschar? A spider bite, scrub typhus, anthrax, and ecthyma gangrenosum. So, you should be remembering these four causes of eschar as well. Coming back to the question, look at the eschar here with fever. Your correct answer will be option B, that is doxycycline. So, this is going to be your correct answer in this one. Which of the following best describes oral lesions seen in Kaposi sarcoma? Kaposi has been a favorite again. It is a NEET PG 2023 question, especially oral lesions of Kaposi. Then in your FMG July 24 also, they asked CD4 counts for Kaposi. Again, you see the repetition asked in a different manner, but the topic remains the same. How would you describe oral lesions here? Whether these are white flat patches, ulcerative painful nodules, red smooth non-elevated macules, or purple red elevated lesions. See, white flat patches, definitely not. Why? Because what is Kaposi? Kaposi is a vascular neoplasm. So when anything is vascular, it is going to be reddish in color. So you have to know that Kaposi is a vascular neoplasm. Of course, if it is made up of blood vessels, if it is made up of capillaries, it is going to be red in color. Can it be white? No. Would it be ulcerative, painful nodules? No. Would it be red, smooth, non elevated macules? This is a neoplasm. Why would it be non elevated? Why would it be smooth macules? That is generally not how a cancer presents, right? Cancer is not going to have a flat, smooth surface. So this is out. Purple, red, elevated lesions. Most of the cancers would be proliferating. Lesions can get elevated. So the correct answer here is option D, that is purple, red, elevated lesions. This is what you see in Kaposi sarcoma. See, this is a vascular neoplasm. can affect the mucosas, can affect the skin as well. So this can affect mucosa, it can affect the skin. What is the virus implicated in the etiology? Human herpes virus 8. Common in people who are suffering from HIV, develops when the CD4 counts fall below 200. So what are the important points you have to remember? This can affect the mucosa as well as the skin, caused by HHV8 in patients with HIV at CD4 levels under 200. This was your last year's question. Since it's a vascular neoplasm, lesions would be purple red in color. They would be solid raised. So it can be papules and nodules, plaques that a patient presents with. And when you do a histopath, you see a spindle cell proliferation of the vascular channels. So this is what is a vascular neoplasm. You see this image here, purple red lesions here, which are elevated. Here also you see a purple red swelling in the mucosa. So this is what is a Kaposi sarcoma. What type of hypersensitivity reaction will you see in borderline leprosy? Leprosy, every exam, one question is there in the INI, in the NEET PG, in your FMG exam. So leprosy is a very, very, very important topic. Here also see, I've actually received 2 questions on leprosy here. Now, what type of hypersensitivity reaction will you see in a borderline leprosy patient? See, what are the 2 types of leprosy reactions? We have type 1 reaction and we have type 2 leprosy reaction, right? When we talk about leprosy reactions, these are type 1, type 2. Type 1 generally happens in borderline leprosy, whether it is BT, it is BB, or it is BL. These are more prone to type 1 reactions, while type 2 happens only in LL leprosy. So that's a very basic that you always read when you're reading leprosy reactions. So what is this type of hypersensitivity? What is the type of reaction? It is a type 1 reaction. Now, they are not asking you what is the reaction. So please don't mark type 1 here. Read the question properly. They are asking you what type of hypersensitivity would you see. So type 1 reaction is generally a type 4 hypersensitivity, while type 2 is a type 3 hypersensitivity. I tell you how to remember. 1 plus 4 is 5. 2 plus 3 is 5 again. So what is the type of HS here? It is type 4. So this is a question where you actually had to read what they are asking. It is not a type 1 that they are asking. They are asking the type of hypersensitivity, that you would see here. So what is the reaction in borderline leprosy? You would see a type 1 reaction. And what is the type of HS? HS is type 4. So the correct answer here is going to be option D. That is a type 4 hypersensitivity reaction in borderline leprosy. Are you getting it? This is a tongue twister. This is actually a question that's asking you to differentiate, read properly, and see what they are asking. Another question that I received on leprosy reactions, I don't know if both were there or there was just one of them. You'll have to tell me which was there or both were there. A patient presents with red a patient presents with red tender nodules over the body after stopping MBMDT. What is the most appropriate management? See, now if the patient is taking MBMDT, that means this is a case of leprosy, right? Even if the question does not clearly tell you the diagnosis, it is telling you the treatment. Like if a question tells you patient is taking ATT, it means patient is a case of tuberculosis. Patient is taking ART, is a case of HIV. Similarly, here, if the question is telling you that this patient is taking MBMDT, that means it's a case of leprosy. Now, leprosy patients would have leprosy lesions. That's obvious, but they are not red tender. So, what is this patient actually developing? See, a leprosy patient, when he starts MBMDT, either during the treatment or on stopping the treatment, or even after many years, patient can develop what is called as a leprosy reaction. What is called as a leprosy reaction. Now, when a leprosy reaction, I told you, could be a type 1 reaction, could be a type 2 reaction. In which reaction do you see red tender nodules over the body? These red tender nodules, what are these? These are actually ENL lesions, which you see in type 2 reaction. So the question here is telling us that this is a patient of type 2 reaction. I think in some of the wordings, I've also seen that he stopped MBMDT on his own, or he stopped after the development of these lesions. So that is not clear as to what the phrasing was. But this is a patient who maybe stopped MBMDT prematurely, or he developed these lesions and then he stopped his treatment. Whatever it is, the diagnosis here is a type 2 leprosy reaction, and the patient is developing ENL. Now, what would be your appropriate management to a patient with ENL? Would you stop all treatment? No, patient is developing a reaction. He could develop systemic complications. He could develop neuritis, palsies. So you don't stop all treatment. That is definitely not going to be your only answer. Would you restart MBMDT? Depends again on the phrasing of the question. If he stopped the treatment after development of the lesions, you cannot, stop MBMDT, you definitely have to restart it. But would that be the only thing that you do? You restart MBMDT and you send the patient home? No, this patient is developing a reaction. He's in a type 2 leprosy reaction. You have to manage the reaction as well. So, how would you manage the reaction? Yes, you would restart MBMDT. You would restart MBMDT, but you will also manage the reaction with steroids. So the complete management of the patient is going to be restarting MBMDT with steroids. MBMDT would take care of the disease, steroids will take care of the reaction. So this is going to be a correct answer. Send biopsy. This is generally a clinical diagnosis. Patient of leprosy comes to us with fever, these red tender nodules on the body. We know we are dealing with ENL. So whether we send a biopsy, we wait for it to return and then start treatment, that is not the case. We may or may not send the biopsy, but we'll definitely start steroids in the patient. We'll definitely restart MBMDT. That would be the next best step that we do. So correct answer here is going to be option C. Biopsies we generally don't do in the reactions. We don't need a confirmation. It's clinical thing that we see. So these are the leprosy reactions. It could be type 1, it could be type 2. What is happening in the type 1 reaction? You see there is redness and swelling happening over the pre-existing leprosy lesion, while in type 2, you have these red painful nodules all over the body, which are called as ANL. So very different from each other. Type 1 would just involve the leprosy lesion. It becomes red, it becomes inflamed. In type 2, you see a classic happening, which is erythema nodosum leprosum, red painful nodules on the body. So how do you differentiate between these two? A very important table here. See, they've ended up asking this. So type 1 reaction is actually a type 4 hypersensitivity. Type 2 reaction is actually a type 3 HS. Again, 1 plus 4 is 5, 2 plus 3 is 5. So that is a very important point that you remember. Type 1 reaction seen in borderline leprosies, while type 2 is seen only in the lepromatous leprosy. So in the first question, it was a patient of borderline leprosy. He would develop type 1, which is a type 4 HS. Here, only the leprosy lesion is inflamed. As I showed you in the image, that becomes red, swollen. You may see that the nerve around the lesion is inflamed, but no systemic symptoms, no other internal organ involvement. That is a type 1 leprosy reaction. Type 2, seen in LL leprosy. LL leprosy as a disease involves almost your entire skin. There is a diffuse involvement, there are internal organ involvements. So when you have diffuse involvement of the skin, you would have lesions all over the body as well. So these will be red painful nodules all over the body. These would be red painful nodules all over the body. Is that clear? Red painful nodules all over the body. This is erythema nodosum leprosum. Yes, neuritis can be there, internal organ involvement can be there, fever, joint pain can be there, all of these can be there. What would you do? You would continue MBMDT and you would start steroids to manage the reaction. This is a NEET PG 2022 question. This has been asked in the INI many a times, and now it has spilled over to the FMG as well. So this is actually, I would say, a direct repeat from the NEET PG 22 paper. Very, very, very important. Now, a diabetic patient presents with whitish oral lesions as shown. KOH mount shows budding yeast and pseudohyphae. Which of the following is the most appropriate culture medium for isolation of this organism? So what do you see in the image? In the image, you see these white pseudomembrane. You see this white pseudomembrane all over the oral mucosa. This patient is also diabetic, increases your risk for infections. KOH showing budding yeast, pseudohyphae goes in favor of this being a candidial infection. So what are we dealing with? We are dealing with a oral candidiasis or a pseudomembranous candidiasis. How do you culture candida? Chocolate agar? No. Loeffler serum slope? No. Thiamartin? No. What do you do here? You culture it on the SDA medium. So quite a simple one here. All you had to do was identify budding yeast and pseudohyphae, know that this is oral candidiasis. The culture medium here is Sabouraud's dextrose agar. So see, this is how they integrate dermatology and microbiology. They will give you the whole clinical scenario and they'll ask you a question from microbiology. So this is like what a classic integration is. This is what is, their modus operandi. Ask you, see, this is oral candidiasis. Risk factors for oral candidiasis: somebody who's a diabetic with high sugars, who is an HIV patient or a cancer chemotherapy patient, or somebody who's using the steroid inhalers improperly in oral candid, So when you are not taking your steroid inhalers properly, the whole steroid will deposit on the mucosa, cause local immunosuppression, increase your risk of candidiasis. So these are the classic scenarios what you get. What did I tell you? Somebody who's a diabetic or an HIV or other causes of immunosuppression, or a steroid inhaler not taken properly. These are the classic scenarios for oral candidiasis. How does the patient present? Can present with white candidiasis. Some of them can also present with the red lesions, which is called as atrophic candidiasis. But most of the questions in the FMG exam, they ask you white candidiasis. That is the pseudomembranous candidiasis, also called as oral thrush. When you scrape it off, it comes off, or you can rub it off, leading to a bleeding erosion. You can lead to a bleeding erosion. So that's how you identify that this is candidiasis. You do a KOH mount. KOH mount will show you budding yeast. It will show you these beautiful pseudohyphae. The culture medium will be the SDA that you use for the identification. Treatment of choice, fluconazole orally works well. So what is the correct answer here? Correct answer here is option B, that is the SDA medium. A young patient presents with multiple dark brown to black macules on the lips and the buccal mucosa. Colonoscopy reveals multiple hematomatous polyps. What is the likely diagnosis? They give type with greater auricular nerve. Dr. Madan, I'm just seeing this. Can you tell me what was this? Type plus greater auricular nerve. Which question was this? Okay. Okay, so we'll come back to that question coming to this one. A young patient presents with multiple dark brown to black macules on the lips and the buccal mucosa. Colonoscopy reveals multiple hematomatous polyps. What is the likely diagnosis? A very simple one here, often asked question. These dark brown to black macules on the lips and the buccal mucosa, these are lentigenes. Colonoscopy is showing polyps. So where do you see lentigenes with polyps? Peutz-Jeghers syndrome, familial adenomatous polyposis, Gardner syndrome, Cronkite-Canada syndrome. Polyps, polyps can be seen in all of them. These are all polyp based syndromes, that is polyposis. But which of these shows lentigenes on the lips and the buccal mucosa? That is only and only Peutz-Jeghers syndrome. So the correct answer here is option A, that is Peutz-Jeghers syndrome. Familial adenomatous polyposis does not really have any specific cutaneous findings. Gardner syndrome can show epidermoid cyst, lipomas. Cronkite-Canada syndrome can show some diffuse hyperpigmentation. It can have alopecia, it could have nail findings, but it does not show lentigenes in the oral mucosa. So, this is a very classic FMG question, but this is also a very favorite INI question. They love asking these polyposes and their cutaneous findings in the INI exam. Very, very favorite of them. But here they have asked a simple one, that is Peutz-Jeghers syndrome. So remember, when you see these kind of dark brown to black macules on the lips, on the oral or the buccal mucosa, around the mouth, this is classically seen in Peutz-Jeghers syndrome. Very, very, very important image here. Very important clinical scenario as well. Coming to the last question, a woman presents with sudden onset high grade fever, hypertension, diffuse rash, history of using tampon for an extended period of time. What is the most likely diagnosis? What is the most likely diagnosis? So clinical scenario here is patient has a multisystemic disease where there is fever, there is hypotension, there is a diffuse rash, and a classic history of using tampons for a long time. I hope all of you got it correct. This is, a good one here to give you that 1 point for sure. Septic shock can present with hypertension, fever, but it will not have the skin rash. Pelvic inflammatory disease would not present with a skin rash. It would not present with these findings. Staphylococcal scalded skin syndrome will present only with rash. This generally does not have any hypertension. It does not have a tampon, because this is seen in babies. So for staphylococcal scalded syndrome, your clinical scenario will be an infant having a staphylococcal uh, infection, like in the otitis externa or anywhere, and then develops a rash. So the clinical scenario is going to be very different. And moreover, this is going to be a baby or an infant who presents with SSS. The only one where the tampon fits with multisystemic findings, this is your toxic shock syndrome. Classic tampon takes you there. So with this, we finish our discussion. I will have to rework the leprosy question after taking the cues from you all. Thank you so much. Any other question asked in dermatology, please leave it in the comments. See, most of these questions, other than Peutz-Jeghers, are infections. There is no question on psoriasis, vitiligo, alopecias, even acne, eczemas. These have been favorites of all the exams, and in this exam I have not received a single question on core dermatology. The focus has been on infections because, as I told you, it tries, it integrates all of them. So if you have any other questions, please note it down for me. For now, uh, this is all from my side. All the best for the result. Hope you cross that very important mark of 150. All the best for you all. Thank you.